Hello.
Oh, there she is. Dr. Carrico is an associate professor at Duke University and in radiology department. She has kindly donated her time to speak with us today about small bowel obstructions, and I will I will stop sharing so she can start sharing her own screen and begin delivering the course. Now, I really encourage everyone who is here. We have about 35 people in attendance. If you can keep your cameras on, that will really help for this to kind of remain like an interactive sphere for us. And if you have any questions towards the end of the program, we will have about 15 to 20 minutes when you can ask questions and we will address them at that time. This will allow us to get through the materials quickly. Dr. Carrico, you should be able to share now.
I did try and share. Can you see my screen? The
Not,
lecture? Not
not,
yet? Okay, let me try that again. My topic today actually is malrotation and malfixation of the bowel. Dr. Maxfield is going to talk a little bit more about other newborn bowel obstructions, so we'll have that lecture coming up on another day. So let me see if I can back out of this again. Hopefully I won't lose everything. It tells me that I actually am screen sharing. So let me see.
We can see the screen.
Let's see. Let's try this.
seems they're able to see the screen. Let me check my own view.
Can you see the lecture?
Yes.
Yes, you can. All right, excellent. I am going to actually turn the image of myself off because I find it very distracting, and just focus on the slides. And then when we get to the question answer, I'll come back in person on the video, okay? So let's see. So, all right, can you see this first slide? It has a picture of me and a little image of a upper GI. I have it being performed. Can you see this slide? I have no financial disclosures relevant to this topic. I just want to make sure we're all seeing the same thing.
Yes.
You can see that. Thank you so much. All right. So in the next 45 minutes or 35 to 45 minutes, we're going to talk about malrotation, malfixation of the bowel. We'll review the clinical manifestations of malrotation and malfixation of the bowel. We'll discuss the imaging findings and techniques that we can use to make the diagnosis. And then finally, we'll review the LAD procedure, which is used for treatment. Before we talk about malrotation and why it's so important, we have to think first about the superior mesenteric artery. The superior mesenteric artery, as you know, comes off of the aorta rather proximally, and it crosses anterior to this third segment of the duodenum. So the third segment of the duodenum is passing between the superior mesenteric artery and the aorta. And this one little artery is exceptionally important because it's supplying our jejunum, the ileum, the ascending, and 2/3 of the transverse colon. So it's essential that we keep that patent. One way that we can help keep the vessel from torquing and torsing is, thankfully, through nature, the vast majority of us have the second, third, and fourth segments of the duodenum, as well as the ascending and descending colon fixed in the retroperitoneum. So by anchoring these segments of bowel, we're essentially anchoring the branches of the superior mesenteric artery. So when the bowel peristalsis, that artery and its branches stay relatively in place. Now, if we didn't have this fixation, then when the bowel peristalsis, it's quite possible, and often it will rotate, the bowel will peristalse in little circles right around the superior mesenteric artery. So when you twist the artery, just like if you were drinking from a straw and you twist it, you would occlude the lumen. So when the artery is twisted, the lumen is obstructed and we lose perfusion to all of that important bowel. Also, we can obstruct the duodenum, and usually it will be obstructed very proximally right here at that mid-third segment. And my little green schematic here is of the gallbladder and the bile duct. So we know bile has already entered the GI tract here in the second segment. So we could have an obstruction very proximal of the duodenum. And when the child vomits, we would have bilious emesis. And when the vessel torques, we get the ischemia of the vessel, which could cause serious abdominal pain. So it's not surprising that our most common clinical presentation in our infants is going to be bilious emesis in the newborn. So when they torque, they're going to have horrible abdominal pain, but the babies just cry, so they can't tell us they're in pain. And then the bile builds up in that second segment of the duodenum due to the proximal obstruction, and the baby vomits bile. Sometimes the person will volvulize and then they will unvolvulize. So the pain will be resolved, the vomiting will not occur anymore because the obstruction's been resolved. So in older children and adults, sometimes will have the history of intermittent abdominal pain. They have pain when they volvulize, but then they untwist. Or they'll have cyclic vomiting episodes where they'll vomit when they're volvulized and then they untwist. Problem is they don't know why they're having the pain. They don't know why they're having the vomiting until we can help them make that diagnosis. With these intermittent episodes of volvulus, the child may fail to thrive. They can have feeding intolerance, abdominal distension, maybe from intermittent ileus or malabsorption. When they get a little bit ischemic, they have malabsorption because of the mucosa not functioning properly. They can get diarrhea and they can have some blood in the stool. So usually when someone comes into the ER or to see their pediatrician and they have these episodes of abdominal pain or vomiting, oftentimes a radiograph will be the first thing that is acquired. And the abdominal radiograph is usually normal, like almost always normal in patients that have malrotation and malfixation of the bowel, even if they're volvulized. The plain film is almost always normal. So you can't let that dissuade you if you're thinking about malrotation of the bowel. So for many, many decades, the test of choice to confirm that the patient either has or does not have malrotation has been an upper GI fluoroscopic study, usually single contrast. And we use a water-soluble contrast agent that is relatively low in osmolality if it's emergent, because then we know, maybe they are volvulized, maybe they will have to have some bowel resected. So we don't want to have barium in the surgical field. If it's an elective study, just a history of someone who's off and on had these episodes of vomiting or abdominal pain, but they're not having symptoms at the time, then we can go ahead and use barium. How do we give them the contrast? We can have the baby or the child drink it from a bottle or the cup, respectively. We want to make sure that we don't overfill the stomach. If we get the stomach too full, it can make it tricky on the frontal view then to see all parts of the duodenum, but you can see them fine on the lateral view. Sometimes the kids are just too sick, too tired, too unable to cooperate. And in those cases, we may need to place an enteric tube. But remember, if you get that tube into the lumen of the duodenum, you can distort the position of the duodenum. So you may make someone who has who has malrotation look normal or abnormal. And again, you may have someone who's totally normal and make it look like they have malrotation. So we try really hard not to have a tube in the duodenum itself. It's okay to have it in the stomach. All right, so fluoroscopy has been our gold standard for many years. So I'll just walk you through a normal one and the technique that I was taught many, many years ago. So once the patient ingests the contrast or we've instilled it, we place the patient right side down, and that will move the contrast into the antrum. And you can see this person's having an antral contraction right here. And you can see the small pylorus channel. And then here we see the duodenal bulb. And the duodenal bulb we know is in the peritoneal cavity. The second, third, and fourth segment should be in the retroperitoneum. So we watch the patient as the duodenum moves into the retroperitoneum. We watch that contrast start to descend in front of the vertebral bodies. And early in my practice, I would then turn the patient supine, and some people still do this, turn the patient supine, and you can see the contrast moving from the bulb down the second segment, then crossing right to left, and that will be under the superior mesenteric artery, and then ascending left of the spine
Dr.
over the
Carrico,
left pedicles. Yes,
are you able to use your pointer, ma'am?
I am using my pointer. Is it not showing up?
No, ma'am.
Oh, let's see. Let's try this one. Is that showing up?
Yes, yes.
Okay, good. Sorry, I was my little mouse pointer I thought was showing up. Okay, so here we are ascending along those left pedicles. And usually we'll ascend to about the level. Oh, but you know what? If I do that, I can't advance the slides. Let's see if I can advance with the mouse. Okay, we can ascend. We usually ascend to the level of the duodenal bulb. And so all of this second, third, and fourth should be in the retroperitoneum. The only way we know for sure that they are is if we then rotate the patient laterally and see them all overlapping in that coronal plane. So I've modified my practice, and what I do because I know the most important thing is to make sure that this second, third, and fourth segment are all in the same coronal plane. I now turn the patient right side down, fill up the duodenal bulb, watch that contrast descend the second segment. Then when it's crossing from right to left, all right, oh yeah. And when it's crossing from right to left, it kind of looks like it's swirling down here. And then you'll see it ascend, and then it will leave the retroperitoneum and go into the peritoneal cavity as the jejunum. So once I've confirmed that my second, third, and fourth segments are in that same coronal plane in the retroperitoneum, then I turn the patient supine and make sure that the caliber of the duodenum is normal. There are no webs or filling defects. Because really making sure it's all in the retroperitoneum, second, third, and fourth segments is the key portion of the exam that we know we have normal rotation and fixation. So that true lateral view is essential. If the frontal view looks like your typical normal duodenal C-suite, but you haven't confirmed it on the lateral, then you really don't know if they have malrotation or not. So here's an example. If we just look on the frontal, is this duodenum? Are we starting jejunum here? This all is very exceptionally redundant. Where does duodenum start and stop? Where does jejunum begin? But so if we're very meticulous with our technique, you can tell when we start right side down, we fill up the antrum. See how most of the contrast is in the antrum as opposed to the body, opening the pylorus. And then we have this long postbulbar segment. So our last patient, the bulb was immediately next to the retroperitoneum. But in this patient, we have a long postbulbar segment. Then we see it descend in the second segment of the duodenum. And then if we rotate at this point, we'll see that this, as we keep it on continuous while we rotate, this little loop right here is really just the first segment of the duodenum. Then we had the second, the third, and the fourth. And then we leave and go into the jejunum here. But we rotate in continuous fluoro so we can keep our eye on all of these segments. And you see that this loop is our postbulbar segment, and the 2, 3, and 4 segments overlap. So again, that lateral view, very, very important that everything is in the same coronal plane. So we have to make sure that we're in a true lateral view. If I go back, see, I didn't include the ribs on this. I cropped it down to highlight this. But I really should have been showing you the ribs just so you feel confident that indeed I'm in a true lateral view. So if you look at this patient is not on an octagon board. They're just flat on the table, right side down. If we look at these posterior ribs, they are not overlapping with each other. So this patient is very oblique. So here's the bulb. Here's the long postbulbar segment. This is the second segment. Looks like it's descending in front of the spine, but then it looks like the third and fourth enter the peritoneal cavity, which would make us think this is malrotation. But our ribs aren't overlapping just right, right? So we need to make sure that we line the patient up appropriately. Let's see if this is going to play for me. So watch as we rotate the patient into the ribs overlapping perfectly. And you see the second, third, and fourth segments are indeed overlapping. So we know the course is normal. And then we watch the contrast move through to make sure the caliber is normal. So that perfect positioning is really important. Now, another variant aside from the long post-bulbar segment is duodenum inversum. So our normal duodenal C-sweep, we see the second segment right of the vertebral bodies, third crosses midline, and fourth ascends. But with duodenum inversum, we're essentially kind of folding this corner up. So D2 descends right of the spine, D3 ascends right of the spine, and D4 crosses the midline. So this is a normal variant, provided that all of this is in the same plane on that true lateral view. So here are two patients on the frontal view. We can see the second segment descends right of the spine, the third ascends, and then we cross midline. Same here. It kind of gives you that square root sort of appearance. Now, just with the frontal, we don't know. This could be, we'd say, oh, this looks like duodenum inversum. It's probably normal. But again, we have to put the patient in the true lateral view, because if some of this is very anterior, then it really is just malrotation. So here's an example of a duodenum inversum where we have a good lateral view. You can see the bulb. D2 descends right of midline, D3 ascends right of midline, D4 crosses midline. And then you can see we're obliquing here. And then in that true lateral view, this 2, 3, and 4 are all in that same coronal plane. The bulb is out in the peritoneum. So that's another normal variant. So what is it when it's not normal? We'll just see the duodenum not making the normal duodenal C-sweep or not being duodenum inversum. And on the lateral view, it won't all be in the same coronal plane. So here is I think it was a 12-year-old girl. And you can see her duodenum is just kind of wandering off over here to the right. On the lateral view, you can see how far, I mean, we don't even have the spine in the image here. So it's very intraperitoneal course. Here's another little patient who came in with bilious emesis, and you can see it just kind of zigzags its way down the midline. Here's a little one who came in with bilious emesis, and this patient actually has a midgut volvulus. So they weren't able to drink, so we put a feeding tube in. And actually got the tube into the second segment of the duodenum to put the contrast in, but then pulled it back very quickly into the stomach. So we knew the tube wasn't going to distort anything. And if you look, you can see that this second segment is really dilated a little bit before we get to the volvulus. So right here is probably our point of obstruction. And you can see it's looping around the SMA and twisting the SMA as it loops. So the lumen's being occluded of the SMA, the bowel is being partially obstructed. And so this is a midgut volvulus. Here's another patient with a midgut volvulus where we're completely obstructing here as it's wrapped around the superior mesenteric artery. In our prior one, we were partially obstructed. You could see this dilatation, but we are able to get contrast passed into the volvulized loops. But in this patient, the volvulus is so tight that we do not have any contrast passing into the distal duodenum. And if you look, you can see the other bowel loops are starting to really dilate up because they're losing tone because of the lack of perfusion. So this is like that little diagram that we showed before. We've got bile coming in here, so we'll have bilious emesis, but we've got a complete obstruction here at this mid D3 segment. Some patients get worked up for Crohn's because they've got, bloody diarrhea, intermittent abdominal pain, maybe they're losing weight. So this was a patient who had a small bowel follow through to assess for Crohn's disease. And you see all the small bowel is on the right. We're starting to fill colon here, and all the colon is on the left. This is called non-rotation of the bowel, which is a little bit of a misnomer. But all the small bowel on the right, all the colon on the left, it's a fairly stable state of being, but they still can volvulize. So these patients, you know, we want to, if they're having symptoms of intermittent volvulus, they would still undergo the LAD procedure. Another clue that we might have malrotation is if you do a contrast enema or on a KUB, you can tell that the cecum is not located in the right lower quadrant. So the duodenum goes through its rotation and fixation, and so does the colon. And if the colon is not completely fixed in the retroperitoneum, then it's possible that the duodenum is not as well. Now, just a mobile cecum, some of those patients are normally fixed, some are not. But if you have a mobile cecum, it's about 80% chance that you could have malrotation. So this baby, we let his contrast pass, and the next day we did an upper GI. And here you can see we're showing the lateral view. These posterior ribs are almost perfectly overlapped, just off a couple millimeters. But here's that duodenum well in the peritoneal cavity, not close to the spine, just kind of descending in the peritoneum. And we turn the baby supine, you can see it's all right of midline. The little blue dots are the pedicles because it's kind of hard to see them on the little Fluorostore low-dose images. So this entire duodenum was right of midline. He's not volvulized at the moment, but definitely has malrotation and malfixation of the bowel, so he may intermittently be volvulizing. So he underwent a LAD procedure. Another finding that's described with malrotation is having excessive redundancy of the bowel right of midline. Of course, on the lateral view, we'll see that this is not completely all located in the coronal plane on a true lateral. Here's another patient with malrotation of the bowel, and you can see that their duodenum is in the axial plane. It's not in the coronal plane. So if this was normal, we'd have our bulb here filling with contrast, and then we would have had a long postbulbar segment. It would have descended in front of the spine, ascended in that same plane, and then moved forward into the peritoneal cavity for the jejunal loops. So again, that true lateral, seeing all of the duodenum in that coronal plane, the second, third, and fourth segments is really essential. This is a teen who was having abdominal pain and other symptoms that could be due to malrotation, could be due to other GI problems. And he had this upper GI examination. And if you look at it here, patient's right side down, we see all the contrast here in the antrum, passing the pylorus, going into the duodenal bulb. And so this is our long postbulbar segment, D2 in front of the spine, like we always like and hope we'll see. But D3 is extending into the peritoneal cavity, and that fourth segment looks like it's in the peritoneal cavity as well. So again, we know that the lateral view is the most important. The frontal view might look normal, but the lateral view is the one that cinches the diagnosis of whether everything is fixed in the retroperitoneum or not. So this patient was diagnosed with malrotation of the bowel. But reviewing their entire jacket for a surgery conference, I noted that they had had an MRI, and the second, third, and fourth segments of the duodenum were all seen in this coronal plane in a sub-centimeter slice. So I knew the duodenum was fixed in the retroperitoneum. So what had happened was that the patient was not in a true lateral position. So if you don't ever include the ribs, you don't know if your patient is obliqued or not. When they were looking under the tower, it looked like the patient was in a true lateral, but really they weren't. So had they included the ribs on the field, they would have seen that the ribs were not overlapping. So we always want to rotate the patient until we're sure that we've got the ribs overlapping perfectly. And I usually look at several pairs of ribs And I keep my hand on the patient's hip so that they don't wobble too much, so I can keep them in a true lateral position. So this was a false positive. So you got to really be meticulous with your positioning and use all the bony landmarks that you can. This is a case that was thought at first to maybe represent a malrotation because it looked like the duodenal C-sweep was right of midline. But if you look carefully, the patient is actually rotated quite to the right. So midline is actually being displaced here. So again, positioning is important. There was a really nice study performed in 2011. It's been a long time, but at the Massachusetts General Hospital, where they looked at patients of all ages that came in with malrotation and malfixation of the bowel with or without a volvulus. And sure enough, in those infants, less than 12 months old, bilious emesis in the newborn was the most common presentation. But you'll notice once people are able to talk and tell you that their abdomen is in great pain, that abdominal pain becomes the presenting symptom. And emesis becomes less frequent as a presentation because, again, the person can tell you they're in terrible pain from this volvulus, from either the bowel obstruction or from the vascular occlusion before they get to the point of actually having emesis. For our little babies, they often are diagnosed within hours or maybe days because that bilious emesis is really an attention getter, as is the continuous crying. But when you get into the older patients who will have episodes of volvulus and then they'll untwist and feel better, and then they'll volvulize and then they'll untwist and feel better. You'll see that if you look through their history, they've had these symptoms off and on for years, but because they keep detorsing, they never come to the point of actually getting a diagnosis made. For our babies, we usually do that upper GI examination. It's the classic. But as we get older, CT and ultrasound take a larger role in assessing the bowel. So we're looking to CT and ultrasound for more information in our older patients. I also think it's interesting that if you explain to the family that they may lose their entire small bowel and part of their colon if this happens again, or if they stay volvulized, that 100% of the parents agree their child should have a LAD procedure. But if you look at an adult who's had symptoms off and on for years, if they detorse, only 39% in this study elected to go ahead and have the LAD procedure at that time. I personally would have it if I found out I had malrotation. Don't want to risk losing all my gut. All right, so what do we look for on CT and on ultrasound? Most of our plane of imaging that's going to be really important is up here at the level of the pancreas. So this is an axial image, and we're at the level of the pancreas, and I've kind of put the vertebrae in black here. And then you can see the aorta. The inferior vena cava is over here. We can see the left renal vein crossing under the SMA, as it usually does. Here's the superior mesenteric artery, and here's the superior mesenteric vein. And this is the typical alignment that we see. This is the typical relationship that we see of the superior mesenteric artery and the superior mesenteric vein. Now, memorizing things can be tricky, but if you think about why the vein would be on the right, it might help you remember why the superior mesenteric vein is going to join the splenic vein. It's going to form the portal vein, and the portal vein is going to the liver, and the liver is on the right. So we think of that vein being on the right as the normal state of being. But when you look at all comers, we see patients that have normal rotation and fixation, sometimes with the vein on the right, sometimes the vein's anterior to the superior mesenteric artery, and sometimes it's on the left. George Taylor at Children's Hospital Boston did a study, and he looked at CTs on 100 control patients and saw that when the vein was on the right, the patient usually had normal rotation, 79%. When it was anterior, about 10% of those, 10% of the normals who had the vein, 10% of normals had the vein, excuse me, directly anterior to the artery, and 11% of normal rotation and fixation had the vein off to the left. But when he looked at the malrotation population, you can see it's the minority of the patients with malrotation that have the vein on the right. And that frequency of malrotation increases the more leftward the vein is. And of course, if we start to see the vein wrapping around the superior mesenteric artery, then we know we're volvulizing. So if we look at these two patients who came in with severe acute abdominal pain, if we look here again at the level of the pancreas at the origin of the superior mesenteric artery, in this patient, the artery is originating from the aorta, and we can see the vein on the right. So we know this patient is likely to have normal rotation. We can scroll down and see if we can see the duodenum passing under the SMA for further information and confirmation. Here's a patient, and you can see the SMA coming off of the aorta, and here's the vein, and it's on the left. So this right away lets us know this patient is much more likely to have malrotation than not. And again, we can scroll down and try and see where our colon is located as that may help. This patient went on to an upper GI examination, and it's one that I showed you earlier. And indeed, she did have malrotation, but she was not volvulized at the time of the CT. But she may have been, and that may have been what brought her into the ER in the first place. She may have been acutely volvulized. So this patient will undergo a LAD procedure. Here's another patient who came in for severe acute abdominal pain. And if we look just at the vessels, we can see that the superior mesenteric vein is anterior to the artery. So that we know this patient is more likely to have malrotation than not. And if we look at the gut, we see all the small bowels on the right, all the colons on the left. So indeed, they do have malrotation. But the reason for their abdominal pain was that they had appendicitis, which was over here on the left because their cecum was on the left. So this was a case of non-rotation of the bowel. All the small bowels on the right, the colons on the left. It is a fairly stable state. These patients don't typically volvulize, but they can. But this patient, his pain was, of course, due to his appendicitis. Other things we can look for on CT, this image is from one of the patients I saw here at Duke, but this data is from Dr. Taylor's article. So when he looked on CT at patients that had malrotation, the duodenum stayed right of midline in most patients, 66%. A third of them, it would approach midline and then loop to the right and stay in the right side of the abdomen. Only 2.6% were like this patient that I'm showing here, where you can see the duodenum actually passing behind the superior mesenteric artery. But then you can see it does not stay in the retroperitoneum. The duodenum is actually coursing anterior into the peritoneal cavity, and it's looping around. So it is possible to have the duodenum posterior to the superior mesenteric artery, but still have malrotation and malfixation of the bowel. Another thing that we look for is if the patient is actually volvulized, you'll see a mesenteric swirl. You'll see the vessels and the bowels, swirling around the superior mesenteric artery. So just to point out that third segment of duodenum passing behind the superior mesenteric artery does not entirely rule out malrotation. In the vast majority of cases, in his study, what is that, 97.4%, SMA going behind the duodenum was normal. But there is a small number of patients where they still could have malrotation. So just keep that in the back of your mind. Here's a 41-year-old who came in with severe acute abdominal pain. And when we look here again at our level of our pancreas, you can see the superior mesenteric artery coming off and the vein is on the left. So we know this patient right off the bat is much more likely to have malrotation than to be normal, rotation and fixation. And as we scroll down, you can see the vessels swirling around and the bowel swirling around the superior mesenteric artery. So that is the mesenteric swirl sign for this person who was actually actively volvulized during the CT. So recently, we have started screening our patients for malrotation by doing an ultrasound examination before we go to the upper GI. This has been done in other parts of the country, but we just started doing this not too long ago. So here's a patient that had symptoms that were concerning for midgut volvulus. And so instead of going straight to upper GI, we have this ultrasound where we're starting again at the level of the pancreas. Here is the aorta, the IVC. This is the SMV with the splenic coming across. You're going to see the aorta coming off here in a second. So here we are in that plane we've been looking at the level of the pancreas. Now watch as the technologist scrolls from here down towards the lower abdomen. There's the SMA coming off. Here's SMV. Now you see it moving left. And now it's moving under and around. So there's that mesenteric swirl. So this patient was volvulized, so there was no need to move on to upper GI examination. They could just go straight to the operating room. So what we do is we look with our ultrasound. Again, here we are at the level of the pancreas. We expect to see the left renal vein passing between the SMA and the aorta. And we also expect to see the third segment of the duodenum. So we'll start here and scroll down and see if we can confirm that the duodenum is indeed passing behind the SMA. If we can't find that, then we'll move on to performing an upper GI examination. If the clinical service wants us to, again, if we don't see it, it does make it more likely that the person could have malrotation, but at least we can rule out whether they're volvulized at the time or not. Here's another patient who you can see here, we're starting up a little higher. Here is the aorta and the SMV, the superior mesenteric artery and the superior mesenteric vein. And you can see the left renal vein crossing between the SMA and the aorta. And then as we scroll down towards the feet, again, that SMA-SMV relationship is preserved. And you can see the third segment of the duodenum passing between the SMA and the SMV. So thinking about Dr. Taylor's paper, just seeing this, we know that there's about 97.4% chance that this patient is normal, very small likelihood that they would have a midgut volvulus. If you look here, you can see looking at the duodenum, we actually look like we have a pretty good fluid-filled segment. And if you look at their KUB, you can see this patient actually had a duodenal web. So we're seeing that second segment really filled with fluid, the third segment passing between SMA and SMV. He did have an upper GI later, and it did turn out that he did have normal rotation of the bowel. But he didn't necessarily need that. He needed to go to the OR anyway to fix this duodenal web. But this is what we're looking for when we're looking with ultrasound, to make sure that we can see that third segment of the duodenum passing between the SMA and the SMV and the superior mesenteric artery. Passing between the SMA and the aorta, and making sure that as we move from cranial to caudal, that the superior mesenteric artery and superior mesenteric vein maintain that relationship. Now, not all patients with the web are going to have normal rotation and fixation. Here's a patient who you can see again, the double bubble, and we see bowel gas is passing. But this patient was planned to go to the OR the next day, but in the middle of the night started to decompensate. And so we did do an upper GI. And sure enough, no contrast at all would pass that mid D3 segment. We even put a tube in and tried to get contrast to pass, and it would not. So it's important to remember that with our patients with malrotation of the bowel, that 5% of them are going to have a second duodenal abnormality, like a duodenal web, a stenosis, or an annular pancreas. So here we see the duodenal bulb. Proximal to that web, the bulb and the second segment of the duodenum, and you can see how decompressed the bowel is distal to that. And of course, we know that size discrepancy is not going to completely resolve. After surgery, we'll still see that double bubble for some time. So for the 95% that don't have a second problem, they'll just have the midgut volvulus. And so this is what the LAD procedure is. First thing the surgeon will do is untwist this bowel because it looks really tight and occluded. Once they untwist it, they'll look for any adhesions and they'll cut down any adhesions. Here you can see the cecum with the appendix coming off. Then they'll inspect the entire bowel. They'll put the small bowel on the right, put the colon on the left, and you can see the little cautery mark here where they excise the appendix and cauterize the tip. Then they just put that all back in the abdomen, small bowel on the right, colon on the left, close them up. So nothing is really fixed in place. But you have to keep in mind that because nothing is fixed, it is possible to volvulize again. In the US literature, it's about 1% of patients volvulize again after a LAD procedure. In European literature, it's about 3%. So you do keep that in the back of your mind that it is possible. So in summary, malrotation and midgut volvulus can present at any age. So we need to keep that in the back of our mind. Infants are most likely to present with bilious emesis and are quickly diagnosed with an upper GI and are treated with the LAD procedure. And more recently, we may make that diagnosis with ultrasound and not need to do the upper GI if we can see that volvulus. Children and adults are more likely to present with abdominal pain. Vomiting becomes less likely because they can tell somebody they're in horrible pain. They can feel the bowel obstruction and the ischemia. Remember that the plain film is almost always normal in our patients with malrotation and malfixation of the bowel. 5% will have that double bubble, but the rest will usually look quite normal. Enteric tubes can distort the position of the duodenum. So if you use one, do pull it back into the stomach so that you know that the tube is not affecting the way the duodenum looks. So upper GI again is usually our test of our gold standard to rule out malrotation and malfixation. We want to carefully assess the position of the duodenal segments with that very first pass of contrast. And please, please, please make sure you keep those posterior ribs in your image to make sure that you're in a true lateral position. 20% of patients with malrotation will have a normally positioned cecum, but 80% the cecum will be high or it will be located in the left abdomen. 5% of malrotation patients have a coexisting duodenal anomaly like a stenosis, a web, or an annular pancreas, and an abnormal SMA-SMV relationship is suggestive of malrotation of the bowel and warrants an upper GI examination if there are clinical symptoms suggestive of intermittent volvulus or volvulus. I want to thank you very much for your time and your attention. I also want to thank Dr. Elizabeth Tracy, who gave me the surgical images that I was able to show during the presentation.